Our next speaker, Dr. Thompson, is a cardiologist with Cape Cod Healthcare and medical director of cardiac rehabilitation at Cape Cod Hospital. Dr. Thompson attended the University of Maryland School of Medicine and completed her residency in internal medicine at Washington Hospital Center, Georgetown University Hospital, where she also completed a fellowship in cardiovascular disease. She is also the medical director of the Healthy Parks, Healthy People Project, a partnership of Cape Cod National Seashore and Cape Cod Healthcare. And on your way out, we have a couple of info things about the HP 5K race, which is coming up on September 22nd. So if you're interested in that, you can get the information on how to register as well. Walkers or runners are welcome. Dr. Thompson has been a popular and frequent presenter at Wellness Trails, and today she will discuss heart health for women, why gender matters. Dr. Thompson.
Okay, am I on? Can you hear me? I'm a screamer, so. Can you hear it back there? Is it all right? Okay. Alrighty, so thank you very much, Julie, for inviting me again. I love doing this, although the last time I was here was the playoff Sunday, and now I'm missing the first game, so we'll have to plan this better next year. I wanted to thank you all for coming here. I love lecturing. If you're my patient, you know I love lecturing to you. But I love the opportunity to talk to people, not necessarily in the one-on-one that I have as a physician in my office. If you know me as a physician, you know that I wish I had more time with you every single time I see you. The reason being is that as a cardiologist, 80% of what I treat is 100% related to what we eat or what we don't eat, or what we are not doing with our bodies. And I always get jealous when we have some breast cancer discussions, because I always thought I wanted to be an oncologist. I really wanted to be a cancer doctor all the way through medical school, all the way till I had my son, or I was pregnant with my son in my second year of my residency. I was getting ready to go to my fellowship interviews, all ready to go, and I just had this hormonal thing that happened with my estrogen and my progesterone coursing through my body, and I decided I can't see another cancer patient. I can't do it. I can't see all this death. I don't like it. It's not for me. So my husband said, well, why don't you become a cardiologist? And I was like, okay, I don't know. It's usually for guys. It's a guy's world. It's a guy's profession, but I guess I'll check that out. And I actually was fortunate enough to train at a huge heart hospital and had some excellent training and great mentors, and I actually became a cardiologist. But little did I know that the #1 killer of people for the time since Fleming discovered penicillin, essentially, is cardiovascular disease with bullet. Okay, so this blue line is cancer deaths. Okay, so it's been rising, cancer deaths. This is 1950 down here. This is 2014. But more people die of heart disease every single year since 1950 than every single man, woman, and child who dies of every single cancer combined. So my sadness about people dying, and I kind of flipped it on myself. I didn't realize what I was doing by becoming a cardiovascular specialist, but yet I love my job. And the reason I love my job is because I can help empower you. And that's why I love Wellness Trails, because the theme of what we do with Wellness Trails is empowerment. If we can give you a little bit of information about how this body works and help you fight the good fight every single day of the rest of your life, you can be a very old person and a very healthy old person. I have patients who are 100 years old. I have patients who are 65 years old, and a lot of the 65-year-olds say, don't get old. And I have a 108-year-old patient who's like, this is great, I'm going to the town council meeting next week. If you're a healthy older person, you are a happy older person. And if you're not healthy, you're not going to be happy. And there is a mind-body relationship that really does come into play as we age. And being mindful of how we treat our bodies is going to help us improve the trajectory of our health and our well-being throughout the duration of our life, however long that's going to be. So either way, I want us all to understand that as American women, and I know there's a man back there, so sorry, but as American women, by virtue of being born American women, the likelihood that one of us is going to die of heart disease is 1 in 3.7 people. So look to your left, look to your right. Right, one of the people in each of these rows is going to die of cardiovascular disease. Again, I didn't want to become an oncologist because I didn't like people dying all the time. So here I am saying, one of you in every single row is going to die of my disease. Not because I'm a bad cardiologist, but because it would be great to die of a heart attack when you're really, really old and all your friends are gone and you're ready to go and you go to sleep one night and you don't wake up. That's an excellent way to die. And I've seen people do that. I've seen people die in a variety of different ways. That resonates with me. I'd like to have a little bit more control over how my body acts for the rest of my life. And so I try to impart that knowledge that I've gained through my training and my physical and mental and philosophical desire to not get old and sick. And that's kind of what I do as a cardiologist. So going down to this next paragraph here, 82% of cardiovascular disease and 91% of diabetes risk may be prevented, actually this should say can be prevented in changes in diet and lifestyle. So the theme of my presentation today is why does gender matter? And I already just mentioned why gender matters. A lot of people might have been expecting to hear me say, oh, cardiovascular disease is different for men than it is for women. It's not. It's exactly the same disease. We just have fewer cardiologists who are females. 8% of cardiologists are females. And I just said, this is the #1 killer of people, and as American females, this is our #1 health threat. So we don't know about that as much as we should because we don't hear about it as much as we should. We all know we should get mammograms. We all know we should get colonoscopies, but we don't all intuitively know that our major risk and our major health threat is cardiovascular disease. So I want to talk today more about empowering you to understand how you can manage your risk as a female American, because more women than men die of cardiovascular disease every year, and that's been so since 1995. So I want you to understand your risk and how to manage your risk so that we can change some numbers around. So what is the impact of diet on cardiovascular health? So unfortunately, this is a guy, but same for all of us. Our dietary habits as Westerners affect our cardiovascular health risk significantly. #1 with a bullet is diabetes, but of course, along with our diabetes epidemic in the United States of America, we have an obesity epidemic. Obesity is when our body mass index is greater than 30. Our body mass index is how much of us there is, or each one of us there is on our frame. So we'll have some slides about that a little later. I think you can see them in your packet. But a normal body mass index is about 21 to 25. Between 25 and 30 is overweight. 30 to 35 is obesity class 1. 35 to 39 is obesity class 2. And above 40 is severe obesity. What happens when our body mass index is greater than 25 is that instead of having fat like this, like we all have, well, I have, you start depositing fat within your the peritoneum. The peritoneum is the sac that surrounds all of our visceral organs, our spleen, our pancreas, our liver, our gut. All of those organs sit in this sac, and as our body mass index goes up above 25, you can be rest assured that you're not just getting bigger bingo flaps, you're developing a visceral fat pad. Fat that we have in different padded areas of our body is not significantly metabolically active. It doesn't do much. It doesn't burn any calories. It just sits there. Fat that sits within our peritoneum is significantly metabolically active. It secretes hormones that keep it there. It secretes hormones that do not allow you to lose weight. It secretes hormones that are significant cell signaling chemicals that affect our cardiovascular health, not just with the development of coronary artery disease, but with carotid artery disease and cerebrovascular disease. So we want to be aware that when your doctor is talking to you about your body mass index, it is a vital sign, just like your blood pressure, just like your temperature. No one's trying to fat shame you or make you feel bad about not losing that last 10 pounds. What we're trying to help you understand is that this is a significant health threat to you, just like smoking. And we want to try to reverse that. The other major issue with what we eat in the United States is hypertension. So hypertension is a major factor in coronary disease, in cerebrovascular disease, both carotid artery disease as well as small vessel disease in the brains. So we're, all of us, I'm sure, I'm speaking for myself, but I bet I'm speaking for others in the audience, no one wants to become demented. Dementia is a very frightening thing. Most people think that dementia is just Alzheimer's disease. You have a far higher risk of developing cerebrovascular ischemic cognitive impairment, meaning high blood pressure, diabetes affecting the small vessels in your brain and causing dementia that has nothing to do with Alzheimer's disease. So if we can educate you, like I'm going to be doing, about how your blood pressure affects your brain and about how what you eat affects your blood pressure, we can give you some tools to prevent that from happening. This, just by the way, this is coronary arteries. These are very severely diseased coronary arteries. This is the right coronary artery, and this is the left main coronary artery, the left anterior descending, and the left circumflex artery. These are very damaged arteries. They have, they should look like tubes. This is a catheter. This is a coronary angiogram. This catheter is injecting dye into the arteries. The coronary artery should be about the same size and caliber as the catheter itself, and you can see these are blown up and dilated in some places, and then also have these big plaques that are causing blood flow blockage. So this is hypertension is a major contributor to the disease that I treat, which is coronary artery disease. So hypertension, like I said, number one risk for death and disability globally. 1 billion people have hypertension worldwide. Hypertension in our country is usually, we characterize it about of a blood pressure of greater than 130/80. So that's, when we talk about blood pressure in my practice, or when you talk about blood pressure with your primary care physician, the reason why we're looking at 130/80 as the goal is because anything that rides higher than 130/80 millimeters of mercury is causing that kind of damage that we just saw on that slide with your coronary vasculature, with your eyes, with your brain vasculature, with your kidney vasculature. It's very, very damaging. 80 million Americans over the age of 20 are hypertensive. And actually just recently, it was actually late last year, the numbers, or our goal numbers came down a little bit more, which actually increased the total number of Americans that are hypertensive significantly because we lowered our goals. 17% of Americans who have hypertension remain undiagnosed because they don't go see the physician as they should. And there is a reason that we call hypertension the silent killer. You don't have symptoms of hypertension until you have had your heart attack or stroke, unfortunately, or you have kidney damage or have blindness, etc. So we want to always try to make sure that our patients understand what their blood pressure goals are and why, because if your blood pressure runs higher than that, you could be at risk for vascular illness. Now, one of the caveats that I'd like to say about hypertension is I see a lot of patients just simply for their hypertension. I have a lot of patients who come to see me from their primary care physicians because their blood pressure is out of control. They tried this medicine, didn't work. They tried that medicine, didn't work. Got sent home to check their blood pressure 2 or 3 times a day. Now their blood pressure's going up, 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 up. One of the things that I fear when we talk about high blood pressure is that people start checking their blood pressure and checking their blood pressure and checking their blood pressure and making their blood pressure get higher and higher and higher with every single time they check their blood pressure. So don't take this part of the lecture as a signal to go get a cuff or go. Don't do that. Rely on your primary care physicians, but understand that there's a reason that we're talking about these numbers, again, as a vital sign, just like your temperature or your weight. The number one reason that we have hypertension in America is the amount of sodium in our diet. So looking at this graph, this is a typical wedge, this is a pie graph of an American diet, a typical American diet. Almost 80% of the sodium in a typical American diet is already in the food you eat before you think of seasoning it. It's already in the food you eat before you put a little in the pot, in the water. It's 80%, okay? And the amount of sodium that we eat in this country is 4 times what our recommended dose is. So as human beings, we should be consuming between 1,500 and 2,000 milligrams of sodium maximum. A typical American's diet is about 4,000 milligrams of sodium a day. So if you have hypertension and you're sitting in this audience, let me tell you, the easiest way to lose one of the medicines that you're probably taking is to limit your sodium to 1,500 milligrams a day. As every human being is sensitive to sodium at every age, but as we age, our sensitivity to sodium increases, and the duration of the effects of a sodium load increase as well. As an example, when I was in medical school, one of the cardiology fellows did a project. He needed to do a research project to graduate, and he hired the first-year medical students to either eat a Big Mac or a Whopper, and they gave us a Big Mac or a Whopper, so it was like free food. It was awesome. And he had us sitting down, and they took our blood pressures, just like you would get your blood pressure checked at your regular doctor. They took our blood pressure, then they gave us the delicious Big Mac or Whopper, whichever we wanted, and then 20 minutes after we finished eating, they checked our blood pressure again. And they checked our blood pressure every half hour until the blood pressure went back to what it was before we started eating. Everybody's blood pressure went up by at least 30 points after that meal. Some people took 5 hours to have their blood pressure get back down to what it was before they ate it. And they were 26, 27-year-old, healthy, nerdy, typical medical student individuals. So as we know that children have this response, that adults, young adults, adolescents, and older adults have this response. But the response to a sodium load, like a Big Mac or a Whopper, or a typical meal at the Olive Garden, or 99 Steakhouse, or San Diego's, that kind of loading happens every day. And so if one of the things that we can do to empower you guys today would be to understand that the easiest way to control your blood pressure and to control your risk of heart attack, stroke, etc., is to control your sodium. Going back, these are our top 10 causes of death in the United States, just to kind of, again, look at those statistics. 633,842 people. This was 2016 statistics, as opposed to the 595,930 people who died of every single cancer combined. So again, heart disease is number one with a bullet. But I'm just going to go down this list because I want you to understand that heart disease, some cancers, stroke, diabetes, kidney disease, all can be controlled, or our risk for those things can be controlled with diet and exercise. We talked about obesity being the epidemic. If you have a body mass index that's over 25, it's an easy thing to calculate. You can Google it. If you're not super good with the internet, you can ask your doctor what your body mass index is, because again, it's something that we track. What we want to try to do is have people who are in the overweight or obesity categories get back down to the normal category, which is less than 25. Getting back to what Carol was mentioning before, physical activity. So helping you eat better by limiting your sodium and perhaps even moving toward a whole food plant-based diet where you're not eating really any processed foods, and exercise it. As she mentioned, people who exercise lose weight. People who want to lose weight should exercise, because if you don't, if you could be in that lucky 2% who can lose weight and not exercise, but ideally you're going to be exercising. There are myriad health benefits to exercising. There's strong evidence, population-controlled, randomized studies that show that people who exercise have a lower risk of early death, heart attack, stroke, diabetes, high blood pressure, high cholesterol, metabolic syndrome, which is obesity, hypertriglyceridemia, and hypertension, and colon and breast cancer. So I don't know if, I don't have any of those diseases right now, but I'm not 50 yet. But probably the majority of each person in this room, or this room rather, has at least one of those things. So if you exercise, you can lower the risks that are already at work if you have high blood pressure, if you have high cholesterol, if you have diabetes. Exercise prevents weight gain and improves weight loss. It improves your fitness. The more you exercise, the more muscle you have. The more muscle you have, the more you're going to burn calories during the day. It prevents falls. Falling is a major issue. As we age, falls become their own health threat. If you fell and broke your hip, you have a 25% mortality rate just from breaking your hip. Not necessarily because of the broken hip, but because you can get a pneumonia while you're recovering, you can get a blood clot while you're recovering, you can get a wound while you're recovering. So preventing your body from being a fall risk is an incredibly important thing that we can work on with exercise. This is sort of a quickie today, because we always have a lot of questions, so I wanted to make sure that I sort of introduced the concepts that I, as a cardiologist and a cardiovascular specialist, would always want to be able to talk more with my patients about and answer their questions about. All doctors want to talk about those things, but your primary care physician or your cardiovascular specialist may not have the time because they're always getting into, did you have your mammogram? Did you have your colonoscopy? Did you get your flu shot? Did you get your shingles shot? Did you blah, blah, blah. We don't always get to kind of give you that basic information about diet and exercise and how important they are to improving your overall lifespan and your healthy lifespan.